Hello, everyone. I'm very sorry about the technical troubles at the start, and I wasn't sure whether you could hear me or not. So I've just disconnected and called back in. So hopefully everything will run smoothly now. Well, it's Claire Snowden here. I'm co-chair of the Trial Conduct Working Group, and I organise these seminars. Today we have Adi Perkins talking to us, and I know this will be a really interesting presentation because I asked Adi to speak to us because I recently heard him talk at the London School of Hygiene and Tropical Medicine, where he's a trial manager. And I really enjoyed his presentation and thought it would be very interesting to have here and that you would have some really good questions to put to him. So Adi's, as I said, a trial manager at the London School of Hygiene and Tropical Medicine, and he came to join us there in December 2016. He focuses on 2 emergency cardiovascular clinical trials. They're called ERIC-PPCI and ARREST. So you'll hear a little bit about those today. He came to us from Vancouver, where he was a trial manager at the Centre for Hip and Health Mobility, and he has a background in cell and developmental biology, so it's quite an interesting trajectory. He has an MSc from the University of British Columbia in cell and developmental biology. So I'm going to pass over to Adi now. If you can think of any interesting questions as he's speaking, please enter them in the Q&A box. It's helpful if you put them there rather than the chat box. And then I'll come to them as Adi winds up, and we can go over those and have a good discussion. But if you have a microphone and would like to speak, do let us know, because we can let you speak directly and have a good discussion that way too. So I'll hand over to Adi now, and look forward to hearing from you all later on. Thank you.
Brilliant. Thanks, Claire. That's a very kind introduction. And hello to everyone who's listening in and watching today. I can see from the attendees list that we've got quite a few people, which is very gratifying. So, yeah, I hope you all find it an interesting discussion, and I'm very happy to answer any questions. So, as Claire mentioned, this presentation is kind of focusing on some ethical issues in emergency cardiovascular trials that we've come up against and experienced. I mean, working with in the 2 trials that were mentioned, one being the ERIC-PPCI study and the other being the ARREST study. So these are 2 trials we're running in our CTU currently. So just click on the screen here. This is just kind of to get ourselves thinking about it. But of course, if you think about good clinical practice and informed consent, it's a fundamental aspect of GCP. Indeed, is set out in kind of one of the first points of the Nuremberg Code. We're looking for required, voluntary, well-informed, understanding consent of the human subject in a full legal capacity. The Declaration of Helsinki declares that valid consent is properly informed, freely given, and free of any coercion. And indeed, if you look in Google, the arbiter of all things true, informed consent is an essential before enrolling a patient in clinical trials, kind of your top result when you're looking things like this up. The issue, of course, is that there must be exceptions to this, because it's not always practical to gain informed consent. So if it's accepted in the UK, at least, there are some exceptions. If the patient's unconscious, if there's issues around capacity in terms of the illness or the treatment, and if there's an emergency context where there isn't time to consent the patient or it isn't ethically appropriate to be discussing the trial with the patient. And while there is some accepted framework on how to design a clinical trial around the issues above, it's definitely a kind of situation where we operate on a case-by-case basis and look at the necessities of the trial. And that's some of the things I wanted to talk about today in this presentation. So some options we have when we're working with consent in the cases where we can't gain it is, of course, using a consultee to make a declaration on the patient's behalf that they can continue in the trial. That could, of course, be a personal consultee or a professional consultee. Another option would be delayed consent. So that's more the model of using an assent saying, yes, so far I'm fine, and then going towards full consent after the recovery. And the final model will be a deferred consent. So that's research without prior consent, otherwise known as a consent waiver, where the patient is approached only once recovered. And so you don't really bring up and address the trial with the patient before they've recovered, and then we look at them then. So the first trial and the first case I want to talk about is the ERIC-PPCI trial. So this is to do with heart attacks, and the treatment is the application of an automatic blood pressure cuff to the upper arm for 35 minutes with repeated inflation and deflation. And the idea behind this is you're kind of conditioning the body to be used to losing oxygen, which is, in the blood supply, which is what happens during a heart attack. And there's some more limited clinical evidence which shows that this can reduce the amount of tissue death, and so we're looking at it in a broader context to understand, can this make a difference in increasing the outcomes and saving some heart tissue in patients who are having a heart attack. So the patient population that we're looking at when they're admitted to hospital after suffering their heart attack, the majority are conscious when they come in the ambulance, and indeed some bring themselves to the hospital. However, they've usually been given morphine, and they may be under severe emotional stress because it's quite a scary situation. And the morphine, of course, is to counteract the severe pain you can get from a heart attack. So that's going to compromise their capacity as well. However, urgent treatment is required to preserve heart function, and so there is a pressure at the site to treat the patients as soon as possible, and kind of one of the classic hospital metrics which gets tracked is the admission to treatment time. So from the time they hit the front door of the hospital to when they get into the catheter lab and, might be stented or have the, the angiography and the balloon go in to reopen the vessels, that amount of time is a really key indicator of how well a patient can do, and so hospitals pay attention to that. So the time pressure is there as well. So for us, we looked at this and said, what was the most appropriate option in this case? And so we have our personal and professional consultee, our delayed consent model, and our deferred consent model. And so for ERIC-PPCI, we had a look at this, working with the ethics committee, and in the design of the trial, we went with a delayed consent model. And so what that means is that when patients arrive at the hospital, the first thing we'll do is a short leaflet with very simple information on the trial is presented to them. And they don't even have to sign this or read it themselves. It can be read to them by a nurse or a member of the hospital staff as they're coming into the trial, into the cath lab. And then after the fact, once they've had their procedure, then the patient is approached to give their full consent for further involvement in the trial. And this is only done when they've recovered enough to be able to make an informed decision about, whether or not they want to be in the trial. So in the kind of the terms of ERIC-PPCI, looking at the other consent models, we've brought up the consultee or the deferred consent. And the consultee, the issues there were that this could cause time delays, and so that wasn't appropriate because it could delay treatment. And also patients tend to travel to the hospital alone in the ambulance, and if there are family members, they can be following on behind typically, so there may not be somebody available to give the consultee declaration. The other model, deferred consent, was felt that as most patients would be conscious even if there was some compromising through any painkillers or emotional duress, that this model of just not addressing the trial with them at all and looking to talk to them afterwards was not justified in the context of ERIC-PPCI. There is, of course, the issue here that means that we could miss out on the sickest patients, but this was accepted by the management group and the trial steering committee. And what we kind of mean here is that, by not taking in patients who can't verbally assent to the trial, we are losing some patients who maybe are the most ill or having the most severe heart attacks. But this is just an acknowledged limitation of the trial. Interestingly, ERIC-PPCI is running with a sister trial called CONDI-2, which has the exact same eligibility criteria as ERIC-PPCI, but it's run in Denmark. And in Denmark, the model is a little different. So whereas here you have a quite quick transit time from the site of your heart attack, relatively quick, to a hospital, and then you get treatment at the hospital. In Denmark, you typically have a much longer transit time, so ambulances are driving quite a ways to take the patient to a larger center. But once you reach the center, you're being admitted to the catheter lab more quickly. And interestingly, in this context, the Danish ethics committee insisted that patients sign a full consent form prior to their entry in the trial. So that means that the Danish ethics decision was that patients should be reviewing a patient information sheet, and then consenting into the trial while still in the ambulance before they receive the treatment, because in CONDI-2, the treatment was given on the way to the hospital in the ambulance. So it's kind of an interesting idea that with a similar trial, you can have these very different approaches from what is perceived as being the best ethical model or the way to run the trial. Some other considerations that came into play for ERIC-PPCI that we felt important to consider is what to do if the patient does not regain capacity. And so in that case, we could use the consultee model, but only as kind of a secondary backup after the delayed consent. And so, of course, that's next of kin, family, etc. And what happens if the patient chooses not to consent? So, of course, if the patient completely refuses, then they come out of the trial. But we did put a provision in to mean that if they said, look, I don't want to have any more follow-up from the trial, we could keep the data we'd collected so far to understand how they'd been treated when they came into the hospital. Then finally, if the patient doesn't survive the procedure, which is, sadly a not infrequent case in this, given the severity of the health condition that people are suffering in the emergency context, we wanted to make sure we got the, oops, sorry, I skipped ahead there. We wanted to make sure that we got the primary endpoint filled in, but how can we do this without patient consent? And so that kind of covers the idea around data without consent and, of course, the confidentiality advisory group. And so they're a body that can grant exceptions to the laws protecting patient confidentiality and identifiable information. And for ERIC-PPCI, we had approval to use confidential data without consent in specific cases. And so this was, we could get the primary endpoint, which was patient death, for patients who did not survive to be consented. And of course, when you go anything with CAG, you have to have an exit plan to understand, that you're not going to continually use this data and there is a way to get out of it. So that was, for us, it was only accessing confidential data for the shortest time required to anonymize it, and we cannot retain it unless absolutely necessary past the end of the trial. Now, one interesting thing here I think is always worth discussing is what qualifies as confidential data, and it's a little more complex than could sometimes be appreciated. And we all know about the motivated intruder test, and it's saying how could somebody who really wanted to find out who somebody was by their information, it's not just a casual thing, it's someone who's really looking to figure that out. And let's skip ahead here. So here are some kind of examples of what, of different kinds of data, and we like to think about which of these could be confidential and identifiable. And so some of them are pretty, clear. So date of birth, your address, these are things, your name that could identify you. And other things, are a little less clear about what could be confidential identifiable data. Your gender, for instance, it could seem like that's something which is, maybe not identifiable, but if you're running, say, a breast cancer trial and there is, someone who is a man in it, then that would identify them because that's quite a rare thing, but a possible thing to happen. Conversely, your age could be something which could be identifiable. For instance, if you were running a trial into Alzheimer's or dementia and you had someone who is very young, because that's a possibility but a rare thing, there won't be that many people at that hospital who are 20 but suffering from Alzheimer's, and so again, that could become confidential data. So it's just important to note that as you think about confidential data, to really contextualize it in the nature of the trial you're running and to make sense of it in that way. So just to sum up then for what we did for ERIC-PPCI is we could collect only the month and year of birth rather than the full date because that kind of limited the amount that could be identified from it. And for patients who couldn't consent, we would collect a time of death in a range, and so the date of death isn't known because, again, that could be identifiable. So, for example, we'd say the patient died 0 to 48 hours after randomization, and that time frame kind of made it impossible to figure out the exact date of death of the patient, and that was something that we worked with CAG to establish, and was a model they were happy with. So this flowchart just sort of shows, not in kind of a brief way, what happens in the various different consent models that can come for a patient, which comes into ERIC-PPCI. And I think the key takeaway here is just understanding that this is as things go, a pretty straightforward consent flowchart. There aren't that many options as a patient comes in. So, and as we'll see when we get to the arrest trial, in other trials, this can be quite a bit more complicated. So the second trial we want to talk about today is the arrest trial, and that's one that's just got up and running this year, and we're now recruiting patients to. And the goal of this trial is opposed to heart attacks, we're looking at cardiac arrests, so kind of a much more serious medical condition. And it's essentially a strategy trial studying the treatment of out-of-hospital cardiac arrest. And specifically, these are cardiac arrests without a clear sign of a heart attack or other non-cardiac causes. And what we're looking is we're trying to figure out the best way to manage these patients. Do we take them to a kind of specialist heart attack center to treat them with all the kind of collection and bundle of care that comes along with that? Or do we take them on the current standard of care, which is taking them to the closest emergency department to treat them? And so if you have a cardiac arrest, which is known to have a cardiac cause, the current, out-of-hospital paramedic management is to take you directly to a specialist center, which will treat you. But if you have a cardiac arrest out of hospital currently in the UK, and you don't have clear signs of a heart attack, and you also don't have clear signs of other trauma or drug overdose, etc., then the management of those patients is a little unclear, and that's where arrest comes in, is to figure out how we would like to manage those patients. So this trial is recruiting 860 patients across 3 years, and it's just based in London currently. So let's ahead. So there are a few ethical challenges to do with arrest. So this, of course, is an emergency context, and time is really of the essence. Because when you have a patient in cardiac arrest, a few seconds or a minute here and there can make all the difference in terms of their survival possibilities and also in terms of their neurological outcomes post-cardiac arrest. Certainly, patients lack capacity during and after their cardiac arrest. This is an incredibly serious condition where the patient their heart is no longer beating, they're not moving any oxygen around their body, and so there's no way we can speak to them. There's a very high mortality rate. The expected event rate in the control arm of the trial is 60%. So for this popular patients, it's an unfortunate thing, but we do expect that over half of the patients will pass away shortly after their admission into the trial. And so given all of these, how can we enroll patients into the trial and also get a representative sample of the patients across London so we can make very clear decisions about how to manage these patients in future? So again, we kind of think about the same question, which is the most appropriate option to deal with patient consent in this case. So we have our personal professional consultee, our delayed consent model, which would be verbal assent and then followed by full consent post. And then we have our deferred consent model, which is no approach to the patient until after the intervention is being given and they've recovered, and then we move forward to talk to them. So in this case, we went with deferred consent because, this is just the one that really works here. So the Research Ethics Committee approved this, and which allows the patients to be enrolled without their consent. So we have a consent waiver in place. And then once the patient is recovered, then we'll look at seeking the patient's consent when appropriate from the patient or indeed from a consultee. So to kind of go back and look at the other options, sorry, wrong way, the personal and professional consultee was not really a viable thing because, well, there may be somebody present. This is obviously far too emotionally traumatic a time to be, discussing research with that person because their friend or partner, whoever it may be, your family member is, in an incredibly serious health crisis. So you can't really be making very good decisions about how to, whether or not to enroll them in research. The verbal assent for the delayed consent model, again, didn't make sense because, the vast majority of these patients will be completely unable to respond. They're not there. So there is a question here, though, which is advanced dissent. So in the model for arrest, we're not telling people they're coming into a trial until after they've been enrolled. And what if somebody doesn't want to be in the trial at all? What do you do about them in that context? Because, the issue with a consent waiver is you are making the justification that this is a very serious and important question to answer, and it's worth not consulting the patient. But are they able to, dissent in advance? So I'd like to discuss another trial, which is called the Paramedic 2 trial, which is run by the University of Warwick, which is works in a similar context as our trial. So it's out-of-hospital cardiac arrest. And the Paramedic 2 team, as we were designing arrest, were so helpful. So, going through this because they'd faced a number of the similar issues. And so Paramedic 2 is adrenaline versus a placebo in resuscitation. So adrenaline is commonly associated with resuscitation in terms of reviving patients. However, there's no clear evidence which supports its use in that context, and so Paramedic 2 was coming in to run this huge, study across the UK looking at, what is the best way and is adrenaline an appropriate drug to give in that context. However, because of the common association between adrenaline and resuscitation, there was a negative public reaction to the trial, and people were concerned they might be losing out on a very valuable therapeutic should they participate in the trial. And so Paramedic 2 implemented an advanced dissenting system as a condition of their ethical approval. And it's kind of an interesting question is how do you build out an advanced dissent system in the context of this population of patients who don't know if they're going to be eligible for the trial because, of course, it's very hard, if indeed impossible, to predict when you might be having a cardiac arrest. So the solution that came up with was to provide these bracelets, which a patient could wear. They could contact the study team and say, I don't want to be part of this study, which I hear is running in my area. And the study team would send out one of these metal no study bracelets, which then they could wear on their wrist or on their body. And that way, if they were attended to by a paramedic in the trial, they would see this and then say, I'm not going to take this person into the trial. The issue here, of course, and this was, kind of getting into the weeds, but if someone had a metal allergy, then they couldn't wear this, so the Paramedic 2 team also had to produce a silicone version, which could be worn by people who are unable to wear metal if they had sensitive skin reactions to it. And so this was something that had happened in a similar trial, And for us, when we came to designing arrest, this was a possibility for us as well. Fortunately, we've made the argument that an advanced dissenting process similar to that in Paramedic 2 should not be implemented for arrest. And the reasons we made this case is that it could delay patient treatment at a critical time. And as opposed to Paramedic 2, which had this perception of maybe taking away something which was typically being done, both arms of the trial for arrest receive prompt clinical care, either from an emergency department or from a specialist center. And so the ethical committee was happy that we didn't need to go down a similar advanced dissenting system. In place of this, we have a system, though, which allows patients to opt out of being contacted by the study should they be enrolled. And so what this means is they can provide their name to us, and if a patient, when a patient is enrolled into the study, their name is checked against the list, and if they come up, then they won't ever be approached in hospital to discuss being consented and coming into the trial. So, so some of the consent challenges, that we deal with in arrest, which are worth considering, is how do we identify the patients in hospital once they've been delivered? If we didn't include patients who die, that would bias the results, so we need to be able to make sure we can include patients who pass away, and as we've discussed, that's a very large proportion of this trial. It is possible that patients could be discharged before we can gain their consent. Typically the patients in arrest are very ill and will be in hospital for quite some time post-arrest. However, we have had a couple cases where someone does very well after their cardiac arrest, and in that case we want to make sure that we can collect those data, because it's kind of the opposite case in patients who die. If someone's very well, we want to make sure we get their information as well, so that we can get both the healthiest and the most ill patients into the trial. And of course, some patients will not recover capacity for weeks, and so how do we manage those patients as well? So again, we went back to the confidentiality advisor group for arrest, and in this case, we've been permitted to access patient-identifiable data to locate patients who are in hospital before they've been consulted, and so we can figure out their name and stuff, so we can go to the hospital and say, so-and-so came in, can you double-check to make sure they stayed in or were they transferred, and so we can start patient tracking. We can collect non-identifiable data on patients who die, and so we can make sure we get the baseline information, whatever information about their treatment in hospital, and et cetera, so we can get that. And for these patients, the decision from the REC was that a consultee consent should not be sought, so it wasn't appropriate to approach the family members of patients who'd gone into this trial to discuss with them, so we can collect the data up until the point that they passed away. And then for patients who do not consent, we can collect their data as well, specifically the mortality data, so we can satisfy the primary endpoint of the trial. And that covers patients both who lack capacity and are in hospital for quite some time and there's no consultee available for them. And it also covers patients who are discharged and before they could be consented and who do not reply to contact attempts to seek their consent via post. And if they don't get back to us and say, no, please don't collect my mortality data, we have permission from the REC and from CAG to collect non-identifiable information for them as well. So this kind of comes back to the consent flowchart idea that we showed, the one for ERIC-PPCI, which is just a couple of branches, and then this is a much more complex consenting process for ERIC-PPCI, understanding the various ways in which pieces of information we could collect. And so we're not going to go through this because it would take too long, but just kind of shows you all the different complexity that can come out as we understand how to, operate and run the trial and keep patients in it. So a final wrinkle that we faced with arrest was using prisoners and how to include prisoners in the trial. Because in an emergency context, it's not always possible to determine a patient's custodial status. They could be on day release, they could be on parole. And so you could be inadvertently enrolling someone who's a prisoner. And as we all know, prisoners are definitely dealt with under a different ethical scenario, and so in arrest, how do we deal with that? Because the ambulance service who is enrolling patients into arrest goes into prisons, goes into all sorts of different environments, and so to make sure we had a clear ethical covering for that. And so that's something we'd be dealing with, and we're always interested to hear if anyone else in the group who's here today has dealt with a similar thing and how they approach that. So in summary, I think these are just kind of some broad points that, differences in trials necessitate a different approach. And it's not enough to have kind of a set procedure or framework, so you have to be flexible in how you design your trial to best fit its needs. And then, of course, some aspects can be standardized, but it's important to be flexible. And that the guidance available online for some of these things can be patchy and not complete. And so we found that communication with other researchers, particularly the Paramedic 2 team at work, has been extremely helpful in designing, for ARREST in particular, a functional trial, which so far is running smoothly. So just a few acknowledgements to my colleagues in our LSHTM CTU, which I won't go through name by name, as well as the key kind of the CI and the PIs for the ERIC-PPCI trial, which are based at UCL and in Oxford. Then the ARREST trial, which is based at St. Thomas's Hospital in London. The Warwick CTU, to Gavin Perkins and Charlotte Scomper, who are great resources, and the BHF, which funds both trials. And that's all from me, and I think now is a Q&A session, and I would be very happy to chat and answer any questions. And so thanks so much for coming today and for your time and attention.
Thank you very much, Adi. As I expected, there was an awful lot in there, and there's a lot that we could sort of talk about for a long time, I think. It was a really interesting presentation. We do have a question already from Robin Lerner, and he's interested in something that I'm also interested in too, about whether you've made any assessment of how informed the pre-surgery verbal agreement was. Have you been able to look at that afterwards to assess something like recall?
That's a really great question in the context of the ERIC-PPCI trial, so that verbal assent. Not specifically, because we haven't been collecting, or we haven't set up the trial to specifically keep track of how patients remembered, or if they remembered making that assent beforehand, so that we don't have kind of a hard and fast number. But we do have anecdotal evidence from talking to the research nurses who run the trial at the sites for us, and the point is very valid that in many cases, or in some cases I should say, the patient did not remember making a verbal assent for the trial to take place, because, and I think here there are a few things at play. One is definitely any painkillers, specifically opioids and morphine that were used, could certainly compromise that. The other is just the kind of the very hectic, very stressful situation you find yourself in before, as you're having a heart attack, and some things might not, register, or you might not remember it, and there's a lot of different things going on, a lot of questions being asked, and a lot of people running around. And so, yeah, there were cases where people were not, didn't remember making the verbal assent. And we did see, and again, it's a shame we don't have the hard and fast data on this, but my guess is that for people who did not remember clearly making that verbal assent, they would be more highly represented in the proportion of people who refused further consent into the trial. Yeah, so that would be my assessment. So it is a very interesting question, though. Yeah.
Yeah, it also raises an interesting sort of next question, really, I suppose, which is, if you don't recall giving consent at a later time, does that actually mean that your consent was not valid? It doesn't necessarily. It just means you're in a different state, and recollection might be troublesome, but ability to give consent might not have been. So how you actually assess whether the consent was appropriate in that situation using recall is quite difficult.
Yes, it's a great point, and I think that's why, the assent thing is a funny one, because it's not really binding in any sense. It is more just a way to kind of do the politeness of saying this trial is going on, and give them the option to say no. But in terms of saying yes, it's not very useful in that context, because it's the full consent afterwards. But the recall it's a key point, Claire. Yeah.
Yeah. We do have another question from Katie, but Robin has come back on that point. So I'd just like to read his reply, because I'm not sure whether everyone can see it. I'm not sure whether you can see it, Adi, actually. He says, we face the same issues and use 80% professional consultees. If the quality of the pre-surgery verbal agreement can't be guaranteed, is there an argument that the enrollment randomization decision should always be made by a professional consultee?
Yeah, I'd feel that there is a lot of value in that. Yeah, that you would make that that decision will be made by an attending physician about whether the patient should go into the trial, because the value of that assent is low, and so I think that there's a strong argument to that. And I think it would also very much streamline trial design as well. So there's value there as well. So I think. Oh yeah, I think that Oh, sorry, Claire, go.
No. So I think we've got a slight delay. No, please go ahead, Eddie.
I was just going to say that in terms of only going with professional consultee in that context, then it is a really tricky population in ERIC-PPCI, because you do have some people who have no capacity, and you have some people who drive themselves to the hospital and walk in saying, "I think I'm having a heart attack," and those people do have they certainly have capacity, or at least enough to say yes or no to some brief information. So it's such a heterogeneous population that it makes it a little more complex. And the counterexample being the arrest trial, which is a much more uniform population in terms of lacking capacity. And so that was one of the real challenges in arrest, is getting a system which worked for people who had very little capacity at all, and people who also had driven themselves there and could answer questions and so forth. So that was definitely a challenge. Yeah, your extremes are obviously quite clear. It's the grey area in between as well, isn't it, where somebody moves from capacity to not having that same level of capacity. Exactly. Yeah. I'll go back to Katie's question now, and it's about the Paramedic 2 trial. And she's interested in, the slides about the bracelets. How was the study publicised to facilitate the advanced dissent model? That publicity is crucial. It is exactly crucial, and it's because without the publicity, then it's meaningless. So they think, now I don't want to quote exactly what they did, but they were put up posters in all the hospitals and GP clinics, et cetera, which were based in the areas in which the trial was running, and so people, as they were interacting with the NHS in those contexts, could see that this trial was running and then look up more information and submit their name. And I would want to double check, but I do also feel in their case that there was more active publicity in terms of advertising and in media and stuff saying the trial is running, but I would want to double check that before I spoke to that. But definitely a sort of passive model in which there was information that the trial was running was put up in areas that likely patients would be going to, so GP clinics and hospitals and so forth. And but I can double check about the further publicity with the trial manager for sure. But, yeah, it's interesting to know if it is an effective route. Yeah, I mean, I do know that, and again, I don't want to speak for that trials team specifically, but I do know that they did send out bracelets, but I'm not sure they ever encountered one in the wild, so to speak, in one of the paramedic crews. Yeah. So. Yeah. But I guess that it's still doing its job if people have them. Yes, exactly. If none of those people happen to have had heart attacks, that's one issue. If they have and weren't wearing them, or it wasn't picked up, that's a different issue. But it sounds like you have not encountered that as a problem. Yeah, but you're totally right, Claire, that just because they were never encountered, given the size of the population and the incidence rate of the cardiac arrest, it'd be quite something to encounter one anyways, and just the fact that they're out there they're doing their job. Yeah. I guess there is a population of people who know they're at risk of having a heart attack, and it's more likely that you could encounter those people. So people who've had a previous heart attack, I guess, and people who have conditions where it's a known risk factor. So maybe it's more salient if you can really specifically target some of those people in your local area. That's exactly right. If you can be a little more focused about who needs it and who's getting it, but and then you could look at cases of people with coronary artery disease and precondition conditions which make them more likely to have a cardiac arrest. But it is quite hard to predict cardiac arrest, and so it is a tricky field to work in. There is a model from obstetrics where trials have displayed information in the antenatal clinics about trials that may be encountered should people go on to have an obstetric emergency. And that's an interesting model, and there are papers published about that maybe people who are in sort of relevant clinics in hospitals could have
access to information via those routes, and it just tells them which websites to look at or whatever.
So that's exactly what we're doing for the ARREST trial. So we have posters that tell people it's running in the hospital that they're at, and those go up across the hospitals, but they're more focused in patient-facing areas where people might be coming in, so kind of in the cardiology department, so those people are going to be coming in for some other reason. They might see that trial's running, and also in the emergency departments where, Okay,
well, we've got a question now from Kerry Wolfall, and Kerry's done lots of interesting work around deferred consent. So I don't know whether you have a microphone, Kerry, but if you feel like chatting, that would be nice. But she asks about the inclusion of the opt-out that's being approached after enrollment. She thinks it's really interesting, and have you had many people request it?
We've had nobody request it so far, is the answer. But the caveat there is the trial's only been running in South London since the first patient was put in early February. We've got 36 patients as of today out of a population of 860. So I fully expect that we will have people request it, but we're still in the early stages, and we haven't had anybody contact us as of yet. But I think we will. I'm sure it'll happen, because the information's out there, and the website's set up for the trial, and so I think we'll hear from people. And we like the model, though. We think it's an interesting one to say, I think it is specific to, not specific, but it is a more limited model, because in ARREST, where it is more of a strategy trial than a specific intervention trial, where you're saying, how do we best handle these patients, and which of two great options do we take them to is better, does mean that going into the trial, there's no risk to the patient. And so it is a model which maybe works more in that context of ARREST, but I think that it could be applicable in other ways too, and to limit or to prevent contact with the study team after coming into a trial. So I think we're interested to see how it goes for us. So
it's useful to think about those ways of sort of taking approaches in one field and applying them to trials in another, and that sort of cross-fertilization of ideas is useful.
Yeah.
Khurshid Ahmed asks us to go back to the issue of the bracelet and sort of flips some of our discussion on its head. And he says, wouldn't it be better to ask people to wear bracelets who want to take part instead of who doesn't want to take part? I feel that people who do not want to take part in the study should not be asked to do anything.
It's an interesting point.
There's some interesting things there.
I think you put your finger on. There's a real logistic challenge there. And also a real risk to a trial design there, that if you are asking people who are in another context, again, that is a model that I think would work. But in the issue with cardiac arrest is you have these ambulance services. So say, for instance, London Ambulance Service, which was one of the participating services in the Paramedic 2 trial. I think there were 6 or 7 across the country of ambulance services for participating. So LAS is covering 7 to 8 million people. All of whom, not all of whom, but most of whom are eligible for the trial. They're at least 18, and that's, then if they're not pregnant. And so if they have a cardiac arrest, which then meets the criteria, they could come into the trial. And so there's a real logistical challenge in terms of getting people to wear those bracelets. In that side, you'd be kind of requiring the population of London to indicate that they're willing to be in this trial if it happened to them, because it's such a broad group. I think otherwise the point is well made, that if you had a more limited group, then you could be, it is much preferable to look for, specific interest in the trial than to be taking people. But the trial design worry that I'd have as well is that you want to make sure you get the most representative sample of people, and people who volunteer for trials, you could introduce a risk of bias, and so I think you want to get that really broad swathe, and that's something you often are dealing with in emergency trials, is because you can't really predict when things are going to happen and to whom it's going to happen. You have to cast your net wide, and that's where the ethical challenges come in about having to subvert the usual models of consent and having to do things after the fact once the intervention's already been applied.
Yes, I guess that model could possibly work in something like a small trial that's looking at rare diseases, where people know who that population is, and that population might sort of be research familiar as well, rather than research naive. But it is a big challenge in the sorts of trial that you're you're
That's
looking
exactly right. You know, and if you were looking at, say, in-hospital cardiac arrest, for instance, then I think that is a model. You'd have a population of people who are in hospital and have a risk of this taking place, and you could say, this trial is running. If, you know, you are in the hospital, if you have a cardiac arrest during your stay, are you okay to go into the trial? And they could wear a bracelet, for instance, to indicate that. So when people start doing, you know, life support, they can enroll them right away. But in the out-of-hospital context, I think the field is just so wide that they do it.
Yeah. The topic of bracelets is obviously getting people's interest. So Diana Elbon, who I know you know from the School of Hygiene, is also asking if there's any idea of how many people actually wore bracelets, which is obviously quite a difficult thing to do.
Yeah,
it's a two-part question. We'll return to her second part in a moment.
Yeah, that's a great question, Diana. So I'm trying to remember in my discussions with the Warwick team how many they sent out. And it was in the hundreds of bracelets were distributed, if not just over 1,000. For some reason, the number 1,300 sticks in my mind. But I can check that in my emails after this, Dan, and I can shoot you an email. It's an interesting question, or I can ask Charlotte because we've asked her before, but I forget off the top of my head. But it wasn't none, and they did send out some. So
that suggests that the publicity machine is working as well.
It did. I mean, I think. Yeah, not to, again, you know, it's not my trial or not one that we ran, so not to speak for them, but I think their publicity machine worked, and they also but also maybe more than they wanted it to. There were a couple of articles in newspaper, you know, national newspapers and stuff, which were very suspicious of the trial, and so, you know, so they got lots of publicity, both good and bad, I would say. I think when they were setting it up.
It'd be interesting to speak to people who requested the bracelets to find out exactly what they took the bracelets to mean. Because we're used to bracelets as a way of protecting yourself for things like penicillin and whatever. And it would be really important to know whether people are requesting the bracelets with an understanding of what that was a sign of, or whether it seemed like another health-related bracelet that you better send off for.
Yes, that is a great question.
Yeah, and it could even be possible that people were sending off for the bracelets thinking it was the opposite, that it was to help them get into a trial. It's completely feasible that could exist. So it would be an interesting piece of work to find out what was behind that decision.
I think there'd be a really interesting study in there talking to people about why. You know, I think there, and I think that's something you've looked at as well, I'm sure other members of the group have, is that, and Diana too, is looking at, you know, why do people not consent for research? Because, you know, I think it's a really mixed bag, and there, you know, you definitely encounter some people who are consenting because they don't want the specific intervention or they don't want to be followed up. But I think there are lots of other more nebulous reasons about why people are wary or, you know, just feel it's easier not to be involved in research. And so I think there's always lots of interesting things to think about there.
Yeah, I mean, the comment that you come up with in lots and lots of qualitative work is that people say they want to have the best treatment. So sometimes that's used as a reason for going into a trial, and sometimes it's used for the reason for not going into a trial. And I think research literacy is quite a challenge, really, because there can be an assumption that going into a trial would be instead of having the best treatment, as opposed to the trial exists because the best treatment is not actually completely clear. And it's all subtleties, but you see it over and over again in qualitative studies of why people do or don't go into a trial. The same reason is given both. That leads us on to Diana's question, actually, about research on these topics. She asks, do you think there might be a role for recording consent in these situations? It's a challenging environment to record consent, but what do you think?
In terms of like the pre-surgery assent, Dana, is that what you mean, or?
I think she means consent for going into the trial. So
I see.
There's a very interesting example of your in-ambulance consent process. And some work in Denmark was done many years ago on exactly that sort of topic, but I don't think they recorded the consent. They just carried out the questionnaire afterwards, but it would be really interesting.
So in the context of CONDI 2, our sister trial, when that group, and they're running it, they're getting kind of full signed consent for the patient to go in. And I mean, I think there are certainly issues there about, how valuable or valid that consent is given the context of what the patient is going through. But that their ethics board was happy with that model, and so they went with it. In terms of recording consent, yeah, I think there's certainly a role for, for having that record. It does. I mean, I suppose it does open you to one more kind of avenue for having patient information and data in an uncontrolled way, which is always something to be kind of wary of as you start taking voice recordings of somebody stating their name and consenting. But no, I think Diana's point is a good one, that there could be different models for consent past the typical pen and paper one that we pursue. So, yeah.
One of the models that Diana is asking about is using a phone. So obviously a lot of our clinical processes and research processes have been transformed by the ability to have an iPad or use a smartphone, and whether there might be any role for smartphone technology in making this a sleek, easy process, I would think.
I think so. I think I've just got the gist of Dan's question. I was thinking recording in terms of audio recordings, but no, kind of recording consent in terms of actually making consent and using a phone or an iPad to do that. Yeah, I think there's a real role for that. The sort of example I can give to that is in the arrest trial, randomization is done in the control room for the paramedics, and the allocation is radioed to the paramedics on site, but more and more paramedics are traveling with smartphones and with iPads, and so they could indeed be doing that randomization quickly online during the on-site themselves, and then making that, recording that. And I think that, so that kind of model of using that technology to get consent is a really worthwhile one. And also, when you just, if you connect it up, it would be such a great way to kind of file it all, and everything would be automatically logged and made sense of, instead of having paper forms around.
I suspect Diana was actually thinking of audio recording on a phone.
Oh, okay.
I don't know.
Oh, right.
But even if she wasn't, I think that's a really interesting direction you've taken that in, actually. And maybe you could sort of wrap that whole thing up together. We've covered all of the questions that have come in so far. I mean, a few more may come in, and we've still got a little bit of time, but there's a couple that I wanted to take you back to. The prisoners, nobody's asked about that, but that's a really interesting issue. And also, there was some work some years ago about appropriate names for clinical trials, and this isn't a lightweight issue. I'm not making a joke, but obviously for prisoners coming into a trial called the arrest trial, both the word arrest and the word trial are significant words as well. So it's just flagging that up as sort of another little complication. But could you tell us a little bit more about the prisoners?
Yeah, for sure. I mean,
how you safeguarded that situation.
Yeah, I mean, I think the terminology of the trial is to talk to that for just a quick second. We as a CTU came in not right at the ground level during the pilot trial. We came in partway through the pilot trial a couple of years ago. And just in terms of keeping everyone's head clear, arrest would not be the name I would use for a trial about cardiac arrest, because it gets quite confusing. When people say this patient's in arrest and then the hospital says we know they're in arrest, they're quite obviously in cardiac arrest, and then it becomes apparent that the paramedic means a trial. But no, in terms of prisoners, it's been an interesting headache, I think, as how I would contextualize it, because paramedics go into prisons all the time, but they don't have to actually do any research activities while they're in the prison in terms of the arrest trial. They're attending the patient as an NHS patient, not as a prisoner specifically. And so our kind of proposal, and we're just working through the amendment right now, and so I don't want to, give a hard answer because we're still waiting for the dialogue with the sponsor and the rec to conclude, is that our model is that we are not actively trying to include prisoners. We just want to not exclude prisoners should they be attended to by a paramedic. And so if a paramedic is in a prison or does recruit somebody who's, on day release or parole into the trial who is otherwise a prisoner, then we want that person to be able to potentially stay in the trial but we understand that follow-up will not be possible or may not be possible, and so for those patients, we might just take remote follow-up to satisfy the primary endpoint of mortality and then get some of the farther secondary mortality endpoints, but understand that it might not be possible. But that's ongoing, and that's why we're kind of interested to see what other people's experience has been in that. So.
Yeah, I guess there might not be a lot of experience of it actually, because there may be a lot of trials may just make the decision not to go there. Yeah.
Well, that's exactly right, Claire, and that was our initial decision, is to say, I think the default approach for most trials is to say prisoners are not eligible for this trial, and that is a very sensible default. The logistical challenge that we came up with, or came up against, which necessitated kind of going back and reconsidering our position on prisoners, is there are 2,000 paramedics in London who could be enrolling patients into the trial, and with such a wide population of people who might be recruiting patients, controlling the idea that you can take a prisoner who is on day release, that's fine, you couldn't know, but you can't take somebody who's in a prison specifically. The feeling was that a much clearer approach to this would really facilitate the ability of the paramedics to recruit, and so that's why we went back and we're trying to get a more kind of, a simple answer so we can give to the wider paramedic population to say this is how to think about the trial and what eligibility is and where you can take patients from. So that's what we're in right now.
I mean, they definitely need certainty, don't they?
They do, and that's exactly the point.
Yeah. So Claire Hawkes has taken us to a different area again, which is interesting. She wants to know about the role of PPI in the trials, especially any views and advice about the consent model that you might have received.
Yeah, that's a great question. So in ERIC-PPCI, we were really fortunate to have, apart from the usual bits of public engagement we do, there was a patient who came into the trial who has a really great head on his shoulders about research and about ethics. And so he's somebody who, when we were designing ARREST, we went back to, because he'd already done some bit of patient work and patient speaking in the context of ERIC-PPCI at some meetings and some kind of trial meetings for us. And we went back and said, we're setting up this other trial. Would you be willing to speak with us and talk about the consent models for that and how we worked? And so in designing, the ARREST trial, speaking with people who had kind of specific cardiac events and how they felt about what was appropriate in a research context was really important for us designing that. And so there are two people specifically that we went back and forth with and kind of drafted our proposed model of consenting and enrolling patients in the trial, and then went to them, and then they kind of had thoughts and came back, and we revised and made some changes to make things more open or to make things more clear, and then went back. And so I think the short answer is it was really key, and we think it was really important because this is such a, it's counterintuitive that you might, wake up and regain capacity, and then someone says, by the way, 2 weeks ago when you had your cardiac arrest, you were put into this trial. And the experience in the pilot trial from working with patients is that can sometimes be a very emotionally traumatic thing, is to kind of, in a way, bringing up the trial itself makes the patient revisit their experience, which was obviously a very unhappy one and a very, it was a traumatic one. And so we have to be very sensitive around bringing that up again with patients or their family members to say, do you remember when you thought your father or your partner had passed away? Let's talk about that time. And so in designing when we approached patients, how we approached patients, and what we discussed with patients, the PPI was really key, both from a couple of focus people and also from the lessons we learned working with patients in the pilot trial. So
it sounds like there's a great piece of qualitative research there, actually, that could explore those particular experiences and consolidate the PPI to take it forward to the next trial. That sounds very
I think so. Yeah, I think so, because I think a lot of, and this is something which happens and it's such a valuable resource for us all, is that, as we work with PPI, I think, and Claire, I'm sure of interest here, like developing that qualitative component to get that stuff on record, to, have a strong resource in the literature about how to design further trials is super valuable.
Yeah, I think so. We've got a few questions building up, so I'm going to turn to them quite quickly.
Yeah.
Katie Neville, who asked a question earlier, is obviously really nicely engaged with your paper. She's asking about the ARREST trial again. Did I understand correctly that the CAG agreed to the use of data from patients who had been approached for consent but who had not responded? Is that correct?
Yes, but I think there's that is essentially correct, but there's a slight wording difference which changes things, and that is that we haven't approached them for consent specifically because, of course, in my understanding, once you approach someone for consent and say, here's a patient information sheet and here's a consent form, then if they don't respond to that, then you cannot continue because, you know, you've made the active approach for consent. But what the REC and what the CAG was happy for us to do, and this was actually their suggestion from the CAG, was the letter we send out says, during your treatment for your cardiac arrest, London Ambulance is participating in this research and they enrolled you. And then it says, if you would like to know more, please tick this box and return this in the postage provided, and we will send you a consent form in PIS, and we can also give you a call to discuss the trial and to discuss it with you. So then if they indicate that they would like to know more, then we'll send out the kind of active approach for consent. And the second part of that initial contact letter, and this was the CAG suggestion, which was you say, but please be aware that if we do not hear from you, we will collect non-identifiable mortality data for up to 12 months after your initial admission. And so that's where the opt-out part comes in. So in that case, yes, if they don't respond to the initial contact letter saying, would you like to know more, please know we're going to be collecting this information unless you tell us not to, then we can collect a little bit of non-identifiable information. But if they say they would like to know more and then we send them the consent form for an active approach for consent and they don't get back to us, then in that case, we're out and we don't take any information about those patients. Yeah.
Okay. And another quick question from Pauline Armory. You mentioned the large number of paramedics that you have been working with, and she asks if they're all trained in GCP.
All the paramedics who decide that they would like to participate in the trial get trained in GCP as part of their trial training. Yeah. So
and do you simply ask them to do that because there's a lot of ways to do it, or do you actually take responsibility for training them?
We take responsibility, not us specifically, but the LAS, the London Ambulance Service, has a very nice kind of online teaching system, and they put together like a trial training package, which paramedics can go through remotely on their, to be trained in the trial, and part of that is a GCP training component, and then we get a record that they have taken and passed their GCP, and that's all logged then through the Ambulance Service's kind of centralized online teaching platform.
Great. Yeah. Interesting.
So,
and we've got a comment from Joe Collins. I don't think it is a question that requires an answer, but you might be interested. He wants to tell you about their approach on prisoners in a trial that he's involved in. Doesn't say what the trial is. So there's a question on the IRAS form is around the trial solely for prisoners if being treated as NHS patients. But in those circumstances, they shouldn't be excluded from the trial, and that's been approved by the REC for their previous studies.
Yeah,
so
that's fantastic.
I presume you're familiar with that, yeah.
Yeah, that's exactly the model we're hoping to. And but I'd be really keen to talk to Joe maybe offline more about that. So I don't know, Claire, if you could, Joe, if you're willing, Claire, if you could connect us, I'd love to chat about that. Joe,
do you have if you have a microphone, you could speak to Addy briefly now, or we can connect you later on. I think you've covered. Oh, sorry, are you there? Great.
Oh, hi, Joe.
It's actually Paul Mounted, Ignal. So there's a few of us in a room. So this is on we've used it on a couple of other studies, and really the RECs. I have got an email from a while ago, I think. It is a couple of years old, though, stating that question is solely for, if your trial is solely for prisoners.
Yeah.
That if prisoners have been treated as NHS patients, they shouldn't necessarily be excluded, and there shouldn't need to be anything in your application that highlights prisoners as you're including, if that makes sense, but you're just not actively excluding.
Yes.
So I think I have it from somewhere. I can probably dig it out, but it is quite old.
Yeah, that would be really wonderful if you wouldn't mind. I'd love to kind of to see that, because that's kind of our feeling. We have the same feeling, is that they're not being actively included. It's just that they've been attended to as an NHS patient and then considered for the trial, and so it's not we're not specifically focused on prisoners at all, and we don't it's not as if we're trying to add prisoners either to up recruitment numbers, because, to be honest, we might see one prisoner over the whole course of the trial, you know, so the chances of happening are low. But that's a really interesting experience, and yeah, I'd love to see more of that. So.
I can ping it through.
Great.
Brilliant. Thank you.
Thank you. That sounds good that we can foster that connection for the two of you. And it's not very far from LSHTM as well.
Yeah.
Okay, we're at 1 o'clock and we've covered all of the questions. And as I thought, this has been a really interesting discussion. There's obviously a lot to talk about, lots of different facets to your trials there, Adi. Thank you very much. It was very positive, I think.
I really enjoyed it.
Thank you, everybody, for attending. We're going to have a short gap now for the 2 summer holiday months. So we'll be back. We'll skip July and August, and we'll be back in September. And as I always say, if anybody is interested in speaking, we're very, very keen to have you involved. Or if you have recommendations from an interesting paper of around about half an hour that you've heard recently, that would be great to hear from you. Thank you again, Adi, and thank you, everybody, for coming along. Bye.
Yeah, thanks so much for having me. Thank you.